Thanks very much for that introduction. Yes, we've known each other a long time. As you get older, you know people a lot longer. It's a great pleasure and privilege to be as part of the MDT, and a great honor to speak to you today. I'm going to talk to you about what the pathologist can do for you from a morphological through to a molecular point of view. We initially are diagnosticians, we become prognosticians, but now I think pathology is well into the realm of being a predictor of treatment. And some of the things you're going to hear about a bit later, the tests and the drugs that are available, are very much reliant on what the pathologist can tell you regarding the biology of the tumor. When I was still at the NHLS, one of my colleagues from ChemPath put this, dinosaur DNA, homologous with anatomical pathology. He snuck in and put it on my door. And that's because they looked down on us because we were sort of way behind in catching up with the molecular era. But I think more and more we have now embraced it, and we are the guardians of the molecular diagnostic pathways. Right, we all know about cancer. It's one of the, as prostate, very much one of the most common ones. As I was saying to Lance, I see 2 to 3 to 4 per day that I'm diagnosing every single day, so it's very common. Biopsy is the gold standard, is a core biopsy still, no matter how much we like to look at other modalities. And the thing about core biopsies is they are both difficult and fraught with different diagnoses that we could make. They used to say that to make a diagnosis of prostate cancer, you need a low-power microscope and a high-power pathologist. And it's very much true because the diagnosis is made on the pattern. The cancers of the prostate do not follow the rules of other cancers. They're more based on the growth pattern. So there have been lots of changes in what we've diagnosed, how we diagnose them, but we still have a few cancers that have come through more recently. The intraductal cancer, and I'm not going to go to all of them, but this is an important one because to identify this is identifying a cohort of patients that have a worse prognosis and in fact may indicate an underlying mutation, the BRCA2 mutation, which is we're going to talk about a little bit later to give you an idea how it comes. But the gold standard that we see is the prostatic adenocarcinoma, which there are multiple different types. Now, if you look at the prognostication of prostatic adenocarcinoma, it very much relies on the Gleason categorization or staging system, which has been around for 60-odd years. Dr. Gleason did this in 1962, and although it's been modified over the time, it still is the gold standard, as you saw, for classifying well-differentiated prostatic carcinomas with good outcomes versus intermediate to high risk. The backbone of that is still the Gleason pattern. So your diagnostic acumen is both diagnosing a cancer and doing an accurate Gleason score. In the old days, there were 9 possible scores you could give when Gleason did it. We're now down to about 5 or 6 because we've dropped categories that he initially called 1 and 2, which probably were benign at the time. But with our modern technology, we are able to make the diagnosis of a benign condition versus a cancer condition. So we know that the Gleason score has progressed over the last few years, and it was modified sort of most radically in 2014 when we became more able to grade certain ones, dropped certain types of grading that weren't relevant. And in fact, and I'm still seeing this today, the Gleason pattern 1 and 2 are still being diagnosed by colleagues on core biopsies, and they've been dropped altogether. You cannot diagnose anything under a Gleason pattern 3 on a core biopsy, and in fact, even on a radical prostatectomy, you would be hard-pressed to call it anything under the Gleason pattern 3. So accurate Gleason is very important. We've actually progressed to the stage where the Gleason pattern now is kind of behind the scenes, and we use the ISOP grade grouping 1, 2, 3, 4, and 5, and as you can see, the Gleason pattern fits into that. So very important that the pathologists do an accurate Gleason scoring system. There are a few rules, and I'll come to those because they're quite important, but you can see that from these pictures, they are very subtle cancers. In the blue arrow down at the bottom there, see, you can see a very subtle cancer, and you can only really detect that on low grade, on low power. So what are the major rules of the Gleason pattern? You must score the 2 most prevalent patterns, most and the worst. If there's only one pattern, you double it. So that's where you end up with your Gleason pattern 3 plus 3 equals 6, which is your ISOP group, grade group 1, which is your good prognostic group, your well-differentiated, low-risk patients, the ones that are amenable to follow-up. There are different rules that apply to a core biopsy versus a radical prostatectomy. So on a needle biopsy, you take the worst and the most. So even if there's 1% of a Gleason 4 or 5, and that's your worst, you have to call it a 3-4 or a 3-5 or a 4-5, whatever, okay? Whereas on a radical prostatectomy, it's got to be more than 5% of the total tissue volume. So you could end up having what was called a Gleason pattern 8 on a core, ending up as a Gleason pattern 7, if the 5 pattern is very much under 5% on your final radical prostatectomy. And there are a whole bunch of rules that pathologists need to know, and I'm not going to go into them in great detail. But suffice it to say, you must be very accurate with your Gleason pattern, because that really does talk to follow-up management. And if you get it wrong, the patients are going to get the wrong kind of treatment. And as you'll see, there is poor reproducibility. It's a subjective score. It is said, like with doing radicals, that the more you do, the better you are at it. So experts have a much better concordance than people that look at 1 or 2 cores a month or a week. Okay, so again, discontinued scores, grade 1 and grade 2, you should always question it if you get a grade 2 score. That is like one of the Gleason major or a minor 1 or 2. There is no such thing. The least you can get is a Gleason 3-3, or a Gleason 3-4, or a Gleason 3-5, okay? So it's important. I'm not going to go into the grading changes, but all the articles that you read will still show the significance of doing an accurate and good Gleason scoring system on your cancers. And really, that's the most important thing, particularly where we live in a country where not many people are amenable to having molecular testing. And all the data really points to the importance of accuracy of Gleason scoring. You can get different types in one field, and you can see on this one, just for interest, you've got a Gleason 3 there, you've got a Gleason 4 there, and you've got a Gleason 5 there. So a core biopsy may in fact miss, and people must be very cognizant of the fact that a core biopsy is a tool. You pick up 100th or 1,000th of the actual tissue, you may not have complete concordance. Right, so we have more accurately graded them into the ISUP grading scores 1 through to 5. Just remember the Gleason 2 and 3 are both 3 and 4, but what is important is that a Gleason 3 plus 4 is a 7, which is a grade group 1, whereas a 4 plus 3 is a 7, is a grade group 3. So it's the percentage of 4 that is important. So if you have 51% 4, it's going to be a Gleason pattern 3. Okay. There are different variants that have been described, which are more of a nightmare for the pathologist. You may see these from time to time, but each one of these is ascribed a different Gleason score, which we need to know. Unusual patterns can be a pitfall for the pathologist, and this is where we use all our special stains to make the diagnosis. I could show you all the different subtypes that look like different benign mimics, but just to be aware, that's why you often get your pathologist having to go back and do immunostains and distinguish between a, for instance, atrophic or pseudo-atrophic pattern and not call it cancer. So we have to use a bunch of special stains. There's some variants that are by nature very aggressive, and these are usually associated with the higher molecular groups, and I'm going to get into the molecular very shortly. For instance, the neuroendocrine carcinoma, which is a high-grade malignant tumor, Gleason 5, and needs different treatment. So when we come to the prognostic indicators, we've got the degree of differentiation, the tumor volume, the spread, surgical margin status. I look with fear and trepidation at the thought of having to do frozen sections on every single radical, but maybe we'll get around that. Category 2, volume, ploidy, histological type. And then category 3, this is where the latest is coming in. Things like perineural invasion, you can see that there's a nerve, oops, sorry, one back one. A nerve with perineural infiltration. Important to note that because it does up your ante in terms of aggressiveness of tumor. But the most important thing that are coming through now are the molecular markers. So in summary of what we can do today in the laboratory, we can fill out all these data sheets for a core biopsy, giving very good information. But we still can't accurately predict which cancers are going to be behaving in a more aggressive, nasty fashion. With radical prostatectomies, as you've seen, it looks like a little octopus hanging down there. It's inked so that we can work out the margins. Fortunately, this is post-resection, not intraoperatively. And we have ways of handling these prostatic resections. We chop them up very finely, in fact, the entire specimen, and look for things like marginal involvement, such as you can see there, which I think we saw an example of there. And again, they're data sheets, which again, look at the morphological features. Still, at the end of the day, although that gives us very good data, we don't know much about the biology, and so molecular pathology has made an important impact. We detect driver mutations, oncogenic pathways, and particularly what is important is to pick up the predictive markers, markers that we can identify which talk to giving drugs that may treat specific pathways in the cancers. So from a diagnostic biomarker pathway, we've got the predictive ones, and there are not an awful lot of them that are actually available. Most are prognostic and help us with the diagnosis of these cancers. And you can see there that the ones in red are the ones that are mainly important, and I'm just going to touch on those and tell you a little bit about those, because what I'm trying to give you is an introduction to molecular biology, not a full comprehensive lecture. You're going to get a couple of talks on the drugs that are available. The PTEN homolog is a tumor suppressor gene. It's very important in that if you can detect it, it's an indicator of adverse outcome. So early biological recurrence, high Gleason scores, patients that can develop lymph node metastases, refractory disease. And it also is a potential target as well for rapamycin analogs, which are not really used in great quantity, but are potentially available. We note the loss of PTEN, which is when you have a mutation. It's a suppressor gene, but when you lose it, you basically have the oncogenic process, and this is the poor prognostic feature. So this is a cancer where PTEN is intact, and you can see next to it the PTEN is lost in the tumor cell. So if you can demonstrate that, that is a poor prognostic feature. ETS gene fusion is another marker. ETS is an androgen-responsive promoter of on gene 21, and when it gets transcripted or when it gets fused with particularly the ERG molecule, it is overexpressed. And that means that those patients will respond better to anti-androgens, and it's a better prognostic feature. So it's not per se a marker that we use, but when you put it together with the PTEN, you will see if PTEN is not mutated, good outcome, mutated, bad outcome. And you can substratify those based on ERG positivity or negativity. So very simple immunohistochemical tests can help stratify which patients are going to do better or worse. The final pathway is the mTOR pathway, the PIK3 protein, which is a protein which controls this. And if this is mutated, this leads to oncogenesis. And again, this is important because PIK3 is quite an important biomarker for a target. There's a target to PIK3 mutation, both in breast and in prostate. So one of the ones we can look at is that. So cancer of the prostate has been looked at in terms of its molecular subtype and pathways. And the Cancer Genomic Project has classified cancers of the prostate into 7 molecular subtypes. It's quite complex. I'm not going to show you. You've probably all seen these scattergrams. But based on this, you have 7 different subtypes based on this, which have varying outcomes in terms of prognosis. And this has formed the basis for trying to have a molecular classification for the progression of cancer. So we now have prognostic biomarkers which give us an idea which cancers are going to behave in a worse manner. So you've got a patient with a cancer, it's intermediate grade. Is that patient going to need more advanced or more aggressive therapy? And we have these markers or these genomic tests, which I'm sure you've all heard of, called Prolaris, Oncotype, and Decipher. Now, basically what these are is that you need formalin fixed tissue. It's sent across to the company that does it. They don't release their algorithms or their methodology, and they then process it using reverse transcriptase PCR and come up with an algorithm that then places the cancer in a prognostic group. And different companies, for instance, the Oncotype will give you a report placing the patient there, just talking to where you will need to treat them. You've got the Prolaris one, And the one that's got a little bit more motivation to be used is Decipher, which gives you a fairly complex report as to prognosis and outcome. And this is one of their reports, and here's another one. And they do different reports for biopsies and for radical prostatectomy specimens in terms of treatment. There's been some criticism of this in that they're expensive, the clinical usage is not well documented, and there are some suggestions that just doing a P10 would give you almost as much information. But the one that I think is finding a little bit of traction is the VeriCite one, known as Decipher, which is now included in the NCCN guidelines, and you probably find that that will become more common. In terms of other predictive biomarkers, there are only a very few that we can do. We do genetic testing in the laboratory. We do next-generation sequencing. There are a lot of different technologies. Basically, what that means is you take the tumor tissue, you homogenize it, break it up, amplify it, and then look for gene mutations, either amplification or mutations, deletions, insertions. And this is done in the laboratory. There are many platforms available. All of these are available in this country, and that's the machine and the technology that we have. There's the most valuable person, our medical scientist, and that's the chip that one would put these on. So you can basically work out one mutation. You can do this on tissue and on liquid biopsy. All tumors release DNA into the blood system, and you are able to pick that up and isolate it and do what you could do for DNA on tumor tissue on the plasma or the blood. Things we can look at are circulating tumor cells, CTCs. The presence of these indicates a poor prognosis. You can look for things like the androgen receptor splice variant, which again is a test that has to be sent off to America. It's done by Oncotype. But this is a predictor of those patients that will not respond to drugs like enzalutamide or abiraterone. So if you can show that they have this ARV positive splice variant, there seems no point in giving these. So it's quite a useful test. The last pathway I'm going to talk about is the DNA repair pathway. There are multiple ways that DNA is repaired in our bodies. And one of them is the homologous recombination repair pathway, or HRR pathway, which I'll go into a little bit of detail. But all of us have it. When you have damage from radiation or any other cause of DNA, this is the major pathway at play. We also have the mismatch repair pathway, which leads to microsatellite instability, and the base excision repair, which is the major pathway that comes into play if the HRR pathway is damaged. So what the HRR pathway does under the influence of the BRCA genes is that it repairs DNA. If you have a mutation of the BRCA or BRCA-like genes, it means that pathway is no longer available to fix up the DNA damage. But you have other pathways that can do that. For instance, the SSB pathway and the base excision repair pathway. So our bodies are clever. We've got backup mechanisms. And just to remember that the whole pathway for BRCA repair is not just BRCA. There are a whole bunch of BRCA and BRCA-like genes, BRCA1, PLB2, BRCA2, RAD51, etc. And all of these are at play, and all of these can be missing. So patients that can have a BRCA-like mutation do not necessarily have BRCA itself, but they may have a mutation of one of these other proteins or one of these other genes. And that's why we sometimes miss them when we do just simple BRCA testing. So what happens is that, in fact, all of those ones in mauve are involved in the BRCA pathway, and all of those can be mutated, and many of those play a major role in cancer. So what happens is when you've got a mutation of BRCA or not, or one of the other ones, is that you can't repair your DNA, and that's when you get for instance, loss of something like a suppressor gene, like our good old friend P10. So what happens is BRCA's gone, P10 gets mutated or damaged, you can't fix it, and then you get a loss of a suppressor gene. So it's not the BRCA itself that causes the cancer process, but it's the lack of the BRCA function that leads to cancer or oncogenesis. So if you look at it in terms of prostatic cancer, you will see that the major four proteins are BRCA, 1 and 2, ATM and PLB2. These are found in about 50% of patients that have germline mutations. most of them are in fact somatic. So if you're just doing a germline analysis, you are going to miss a high cohort of patients or a fair amount of patients that actually have a mutation that is treatable. And I'll go into why it's treatable. Now, in terms of localized cancers, those that stay in the prostate, only a smaller percent have these DNA repair mutations. But if you look at metastatic disease, a much higher percent, nearly 25% of them. So that the mutation of BRCA or homologous repair pathways is an important process in developing metastatic disease. So if you've got a cancer sitting in the prostate and you develop one of these mutations, it's far more likely that it's going to metastasize. Going to that one. And just to say that there is an important association with type as well, and I alluded to that when I introduced the concept of the ductal type carcinoma. The ductal type carcinoma, which is also associated with genetic passing down from family to family, is also an indicator of potential BRCA mutations. So you know from looking down the microscope, diagnosing a ductal type carcinoma, that this has a high chance of being one of these BRCA mutated ones. Now, how important is this in treatment? Well, basically what happens is the base excision repair pathway, which is the backup pathway, is modulated by PARP proteins. And if your PARP is intact, that pathway will occur. And this is what happens with that PARP pathway. However, if you use a PARP inhibitor, a drug that inhibits PARP, you prevent that pathway from occurring. And what happens then is you get two pathways where you're getting damage to the DNA, which you can't repair, which then leads to the so-called synthetic lethality hypothesis. So just to go through that, if you have normal cell and you use a PARP inhibitor, you've still got methods to repair the cell. If you've got a BRCA mutation, but still PARP is intact, you can still replace the cell. But if you have an underlying BRCA mutation and you use a PARP inhibitor, there's no way of repairing the cell. And this leads to cell death, which is the method behind using PARP inhibitors, known as the synthetic lethality hypothesis. You'll probably hear more about this in the next talk, but there are two ways you can get this. One is inherited through the germline, which is a smallish cohort. Basically, it's passed down from the mother or father, and you develop a second hit, which leads to oncogenesis. In the somatic type, you don't have the germline pathway, but you have two hits occurring in the tumor cells. So it makes sense that if you're going to look to use a PARP inhibitor and you want to see a BRCA mutation, you must look at the tumor biology. If you want to treat the patient's family and look for kindreds that have got the mutation, then obviously you do a germline mutation. So pathology is about minimalizing everything. I couldn't resist. Mr. Trump is so open to being mocked. But our job is about minimalizing. We take a big specimen like a radical, we break it down, we look at the cells, and now we're even looking at the genes. In terms of biology, what do we do? These are some other tests that one can do. Looking at it, the Keras, the Foundation, the Myriad, Tempus, which are industry available tests. They all look at the same panel. They give you a list of the biomarkers that are mutated, and they give you what's known as the homologous recombination score, HRD score. And if the homologous recombination score is high, it means that patient has got abnormality of homologous recombination, HRR. Now, that is the important thing, because as I said, it's not just about BRCA, it's about the BRCA and the BRCA-like proteins. And also what that does is having an HR deficiency leads to what is called a molecular scar. And that is what we pick up with our molecular testing. The BRCA field, yes, the BRCA-like proteins and genes, but also that molecular scar. And that's what things like Choice, My Choice or Myriad does. And in our laboratory, we do a very similar thing, and this is, I think, my second to last slide, where we look at all the genes. That's where the BRCA would be listed, or the PALB2, whatever of the HRD. But we also look at the things like microsatellite instability, TMB, tumor mutational burden, and then the homologous recombination deficiency score. So you can have an HRD score, which means you need to get a PARP inhibitor drug, without having a BRCA mutation. So it's important to do a test that is comprehensive and looks at all of those. So I thank you very much. I see I've got 21 seconds left. So thank you.
How are we going to get this? And it's the cost of all of these things, and which, if you were to, and will the funders give it? And where do you think we should be going in South Africa specifically to get the activity going?
So two things. No one in this country does things like Polaris or Decipher. Those are not available. The technology, like Oncotype for the breast, it's not available. And the people that have spent lots of money on R&Ding and doing it are making a crock of money out of doing it, so they have to be sent. But that's fine, because you can pack up a single tissue block, select the tumor, and off it goes, and you'll get your score. But that's, as you know, pretty expensive, $4,000 I think for Decipher. So you use the exchange rate for tariffs, okay? But it is available, and I think with certain patients that have funding, it's probably worth doing it because you can work out what treatment they're going to need. In terms of the HRD and molecular genetics, at present to do the Oncomine Plus, which is the test that does all of that, the HRD, the loss of heterozygosity, and the BRCA testing altogether, that's about 40,000 Rand at present, but it is expensive, but it's a very comprehensive panel. Now, we are working with the funders, and we're working with the companies, AstraZeneca, who basically the drugs require the positive test to be used. And we're working with them to try and bring the costs of the chip and the reagents down. And we think we've got a significant, probably down to about 30,000 odd Rand, 28, 29,000, which is not too bad when you consider the cost of doing a couple of PET scans and a couple of MRIs, etc. But unfortunately, everything is costed in dollars, it's costed in euros or yen, whatever. And our exchange rate is certainly not favorable. But it's available. And I think if you're going to do a BRCA, if you want to use a PARP inhibitor in those high-risk patients, I think you're going to hear which patients should have them. It's more sensible to do a full HRD test with the score and looking at all the BRCA type mutations than to just do a simple BRCA test, because you are going to miss, and also a germline one, because you're going to miss a good percentage that have the somatic mutation, and you're going to miss a percentage of patients that don't have the BRCA but are still eligible for HRD type treatment.
Turnaround time.
Okay, and that's always a problem, and it's not our problem, it's not our fault. It actually, from getting the DNA, let's say we get a request on Monday, extract the DNA on Monday afternoon or Tuesday, it takes 2 to 3 days max to run it, so you would get it by Friday. Our biggest problem is getting consent for funding. That can take weeks, months, and sometimes we never get it from the medical aids, and patients have to chip in themselves, and they have to go and sell their houses and cars for the testing or something, or their shares. So that is the biggest pitfall. It's not the actual time from initiation to doing the test. That's quick. That's literally a week turnaround time in our hands. The machine I showed you, the latest machine, has got a turnaround time of 2 days.
Okay, just one question. The biggest punch when you're using a PARP bracket, but there is value in others. Instead of doing an Oncomine Plus, which is all of your potential genes, as well as the score, as well as SI, and how much is it possible just to do an HRD, and how much?
So at the moment, there is no Okay, there is an HRD test that's available, but it's only run on the Illumina Platinum platform, beg your pardon, which no one in this country is running in the molecular diagnostic laboratories. We actually had a workshop about 2-3 weeks ago, so there's no standalone HRD on the Oncomine platform. You can do a BRCA, expanded BRCA panel, which will just look at the BRCA and the PALB, etc. panel, and that is available, and that's about 12,000. That's not giving you the HRD. But we are as I said, we are trying to persuade the manufacturers to come up with just an HRD panel, because it makes a lot of sense. You don't need to do all the things like TMB and LOH and MSI if you're just looking for HRD. But as I say, it's not what we as laboratories can do, it's what chip that's available. Some laboratories are actually just doing the full panel and only charging for the HRD. But that means they're taking a massive loss in revenue.
Thank you very much, Simon.